Yeah, I think what the CONFIDE survey allowed us to do is to ask individuals suffering with inflammatory bowel disease, both Crohn's and UC actually, in an anonymous way, because what's happening in our clinic when we're asking patients about topics such as urgency and even fatigue, there's often this sense that they don't want to bring it up unless we ask. There's often an embarrassment around this topic. Some feel that we don't have anything to do about it anyways, why bring it up? Also, physicians don't even rate urgency in sort of what they're asking, because physicians as well think the patient will bring it up if it's a problem. So and that's also from the CONFIDE. So not only did we figure out that patients often don't want to bring it up proactively, physicians think that they'll bring it up if it's important. So we're at a complete disconnect between what patients want to talk about and what they're suffering day to day that's actually keeping them isolated, increasing rates of anxiety, stress, depression. And we're not even listing it as like the top 3 symptoms that I think are impacting my patient as providers. So I think what CONFIDE survey allowed us to do internationally, so that includes 5 countries in Europe. We also have some Japan data, but also obviously US data, where we actually went into the homes of those suffering rather than waiting for them to come to the clinic and answer the questions that we're not asking. Okay. So CONFIDE does give us an ability to have some visibility into what are the most burdensome symptoms for patients with, we historically reported on UC, and now we're showing that Crohn's disease actually has a very similar burden when it comes to urgency. And I think that's what's shocking for a lot, is that we always thought urgency is related to rectal inflammation. And we're even seeing Crohn's patients who have no evidence of rectal inflammation are still reporting that urgency is a really burdensome symptom. So I think the first way to make it into an actionable item is we just have to ask the question. I mean, we should be asking, our patients, are they suffering from these symptoms, and whether or not, how severe it is. The other thing I didn't recognize is that I'm not just asking yes, no. What we've also learned through this is we have to be asking the severity of the urgency, and the urgency numeric rating scale, which really was brought to life through the mirikizumab UC program and obviously the Crohn's program. But the idea that we're asking the impact on the severity, which means how much it's impacting their ability to function, and on a scale of 0 to 10. So we first have to be able to ask the question correctly, not just do you yes, no in a binary way and then go, okay, that's great, and move on to the next line of question. We also need to ask the severity, and then we even go further. How is the symptom impacting your ability to live your best life daily and for you to be in control? Because urgency, verging on the most severe urgency, incontinence, fecal incontinence, urge incontinence, for example, that is the spectrum through which our patients are isolating and suffering from. So first we have to ask the question, do you have urgency? How severe is your urgency? And recognize that if there's inflammation, that we can do better, because we actually showed in mirikizumab that you can take a patient who has urgency and you give them an effective therapy and their urgency is decreased severity-wise, and even achieve better bowel urgency remission. Now, what I do want to highlight is that not all urgency is driven by inflammation. And the reason why I think that's important is specifically in Crohn's, it's an example that even in patients who have small bowel disease or right-sided predominant disease, the fact that urgency is as frequent as you see tells me that the brain and the gut, but particularly maybe the pelvic floor and that mind-body concept of stress, anxiety, fear of having an accident, perpetuating the cycle of the centralization of the fears associated with having an accident, or what if I'm not near a restroom and I have an urgent episode, and to find out that our patients are wearing diapers for fear of having an accident. That continues no matter how many times I say, and I think you've heard me, how shook I am at the mere concept that I have a college student living in a dorm who is wearing a diaper. And it's still shocking, and I shouldn't be shocked anymore. I should just be doing something about it. So I think understanding the cycle of the anxiety, depression, and urgency in pelvic floor and rectal sort of compliance is something that gets lost. And I think we first have to control inflammation and recognize that even in patients in remission, studies have shown, the music study that Millie Long led, there's other studies, and we're going to be presenting some of that at some of the sympos on urgency this here at DDW, is that you need to think outside the box and recognize that our patients are not focused on healing of the visible colon lining. I don't even think that's like something that's resonating as priority. What they want to know is, I'm glad my rectal bleeding is better, but my rectal bleeding is not keeping me away from living life. So we as a community need to be focused on the symptoms that are actually going to impact our patients' lives the most.